The following podcast is part of a certified educational activity titled Molecular Testing for EGFR Mutations in the Context of a Changing Treatment Landscape, Evolving Testing Options, and Updated Guidelines, What Pathologists Need to Know and Do. Access the entire activity and complete the post-test at www.peerview.com/DZD. Downloadable slides and practice aids are also available.
Hello, my name is Lynette Scholl. I'm an associate pathologist at Brigham and Women's Hospital and associate professor of pathology at Harvard Medical School in Boston, Massachusetts. Joining me in this panel discussion is Dr. Jeff Oxnard, a medical oncologist who is associate professor of medicine at Dana-Farber Cancer Institute and Harvard Medical School in Boston. Welcome, Jeff.
Thanks, Lynette. I'm glad to be here, and I'm looking forward to our discussion today.
Excellent. So let's get started. First, I think it could be very helpful if you'd share with us some foundational information about molecular profiling of lung cancer, especially EGFR-positive lung cancer. How has our understanding of this field evolved?
So it's important first to realize that EGFR inhibitors in lung cancer were initially approved irrespective of genotype, and the drugs in a randomized trial against placebo were marginally effective. In 2009, we identified with the IPASS trial that EGFR genotyping, testing for EGFR mutations in exon 19 and L858R and exon 21, finally allowed us to clarify which patients benefit from EGFR-targeted therapies and which patients should get first-line chemotherapy instead. And that's now evolved over the ensuing years with additional molecular targets, with genotyping to look for resistance mutations like T790M, and with the development and emergence of stronger and more potent and more targeted drugs inhibiting EGFR and other similar genotypes. And so starting with mutations in EGFR being discovered, our care has really dramatically changed over the past 10 to 15 years. So a case that well illustrates that is the patient I saw in clinic, actually, I'm going to describe now, which is a young never smoker, 49 years old. He presented with a lung mass, headache, cough. This was initially found on CT scan. He presented first to a pulmonologist who referred him then to a surgeon. And a surgeon palpated a supraclavicular lymph node and performed a surgical biopsy, which ended up fairly quickly being read out as adenocarcinoma. And he came to see me, in fact, just 4 days after his biopsy. And the specimen was still at pathology. The wet read had shown lung cancer. The pathology had not yet signed it out. It was apparent that there were brain mets on a brain scan. And so he had stage 4 disease and fairly urgently needed care, but pathology was not completed. Molecular testing had not been started. And so I'm trying to figure out how can I deliver for this patient precision genotype-directed therapy in the face of pathology result that's still pending. There are a distribution of these mutations that we're looking for. In a patient like this, EGFR mutations are the most common, but over the past 10, 15 years, we've found now ALK rearrangements, ROS rearrangements, HER2 mutations, RET rearrangements, et cetera, and a growing number of these rare genotypes, each of which are associated with precision-targeted therapies. And if I find one of these, I can get him a precise, tolerable targeted therapy. And if I don't, I fall back on the toxicities of chemotherapy or radiation. And so it's a very urgent decision for him. How effective are they? If you have an EGFR mutation or an ALK rearrangement, drugs can reliably cause dramatic response rates in the range of 70 or 80%. Brain mets can respond. They are reliably effective in a way that chemotherapy is not. And so the problem with this is that getting from that biopsy to the molecular result takes many steps. You have to see the surgeon to get the biopsy. You have to have that pathology review to be adequate. You have to get the molecular testing processed. Each of these steps can take adding up to weeks from a patient needing a genotype to having a genotype delivered. And in fact, what we're increasingly doing is the shortcut. And the shortcut is just jumping directly from the patient to the blood test, which looks for free DNA, the liquid biopsy. And that is our shortcut because it's so fast. But that shortcut has cut out a couple of the most important pieces in there, which are getting a high-quality specimen and having that specimen reviewed by pathology. For this particular patient, I knew that that pathology specimen was pending. It was being evaluated. It would be an opportunity for molecular testing. Actually, we ended up testing it with next-gen sequencing, and it failed. It was inadequate. So at the same time, to move things along, I sent a liquid biopsy. And in fact, in just a couple of days, I had back an EGFR mutation at high level, and L858R was found in EGFR at 34%. I trusted it, and I was able to start him quickly on an EGFR inhibitor, leading to a response of his lung disease, of his brain metastases, and in this patient, a shortcut that circumvented the need to wait for tumor-based molecular testing. And so he could tap into that precision targeted therapy in a way that some patients aren't able to if they're not able to get to a molecular result.
That was an incredibly impressive case, Jeff. Thanks for that overview. Maybe you can summarize then the key takeaways for pathologists that they should keep in mind when considering what oncologists are thinking of when approaching molecular testing.
Sure. I think 3 points. First, that effective treatment of advanced non-small cell lung cancer requires efficient testing for a range of targetable alterations. And the most common of those is EGFR mutation. We need to offer testing. And that's because of two. These therapies are highly effective. EGFR targeted therapies can prolong survival. We have a growing range of effective treatments for resistance. We have a highly tolerable first-line therapy I'll talk about in a moment. But number 3, that there are logistical challenges of getting that molecular testing done and getting patients to those drugs. And we are always looking for help in making it happen. And that's where we need pathologists to help out getting our patients tested so they can take advantage of these targeted therapy options.
So then let's focus on EGFR mutant lung cancer, the most common targetable genotype. What are the current options and what essential clinical data are informing current practice in the first-line setting?
I'd first like to remind docs that EGFR mutant lung cancer is a global phenomenon. Yes, it's more common in Asia and some parts of the world. It is seen in about 15% of patients in the United States, and even that is variable. And there are areas where there's more smoking and its prevalence is lower, in areas where there's less smoking or more Asian individuals and its prevalence is higher. But this is something that occurs all around the world, and even as smoking goes away and smoking lung cancers slowly dissipate with time because smoking is going down, EGFR mutant lung cancer will still be present and will be an enduring phenomenon across the world. Given that, these therapies are very important, but there are a range of different options available in different parts of the world. In the United States, we actually now have 5 EGFR inhibitors FDA approved, but there are even others that are important to keep track of. The first available here in the United States were gefitinib and erlotinib. A similar drug, icotinib, is available in China. And then afatinib, more recently developed a second-generation EGFR inhibitor, dacomitinib, a second-generation EGFR inhibitor that was just most recently approved. Finally, osimertinib, a third-generation EGFR inhibitor. Those were all FDA approved for the common mutations, EGFR exon 19 deletions and EGFR L858R exon 21 mutations, the 2 mutations where you can reliably see effect. Afatinib is also FDA approved for uncommon mutations in EGFR. This includes G719X, L861Q, S768I, due to perhaps a slightly different activity spectrum, though we've seen some data that osimertinib may also be effective against those mutations. There are then a final family of exon 20 insertion mutations in EGFR. These are maybe 5 or 10%, depending how you test, and none of these drugs are reliably effective for this family of EGFR mutations, but there are drugs in development now, and for patients with that mutation, you can refer them for clinical trials. The 2 leading drugs that come to mind now in clinical trials are poziotinib and TAK-788. Finally, there are rare EGFR variants, kinase domain duplications, fusions that can be seen on next-gen sequencing that also need to be kept in mind. So there are a range of different mutations out there, but the most important ones you cannot miss are the 19 deletions and L858R, where we know there could be great outcomes. And how great are the outcomes? The fact is that these pills are dramatically active, both systemically in inducing responses and reducing symptoms, and in the brain. I think the CNS effect is one of the most amazing parts. There are trials that have looked at oral therapy versus whole brain radiation for brain mets in EGFR mutant lung cancer, and oral targeted therapy has a better response rate than whole brain radiation. And it just highlights how potent and transformative these drugs can be. And so we're able to defer chemo, defer radiation. Immunotherapy is not very effective for these EGFR mutant lung cancers. Oral therapy is the key first step and can work for sometimes years. The most recent clinical data that guides this testing is the FLORA trial. The FLORA trial was a randomized controlled trial in the first-line setting comparing osimertinib, third-generation EGFR inhibitor, with prior drugs like erlotinib, gefitinib. In the control arm, erlotinib, gefitinib, we saw a median PFS of 10 months, a high response rate. These are good drugs, good enough that I did not think we were going to be able to beat them. And yet in the FLORA trial, osimertinib had a median progression-free survival of 18.9 months, and indeed, including post-progression therapy, which is common. Patients at progression can still receive them for a while longer. Patients are commonly on first-line osimertinib for a number of years. And indeed, in this trial, we even saw a signal that overall survival might be prolonged. This is not final, but the hazard ratio for overall survival in this trial was 0.63 with a non-significant and yet impressive p-value of 0.007. So we are clearly making an impact here, and these drugs work. Why is osimertinib more effective than other drugs like erlotinib, gefitinib? Tolerable dosing, no need for dose interruptions, effectiveness in the brain. I'm not sure why exactly. Prevention of resistance, but this drug clearly has established now as a very potent and effective first-line therapy and highlights the need to get our patients tested.
That was an excellent summary. Thank you. What about the problem of acquired resistance to initial EGFR TKI therapy? Can you briefly talk about that, please?
Sure. So EGFR mutant lung cancer was the first disease in lung cancer where we found a reliable, recurring spectrum of resistance mutations, the most common being EGFR T790M. This is a gatekeeper mutation. It occurs in about 50 or 60% of patients after receipt of drugs like erlotinib, gefitinib, afatinib. Though there are other resistance mutations as well, we see small cell transformation, 5 or 10% of the time, MET amplification, 10 or 20% of the time, and a range of other potentially targetable resistance mechanisms. Given how common T790M is, it was an obvious space for drug development, and after a number of negative trials trying to target it, we eventually developed these new third-generation EGFR inhibitors. Osimertinib, in particular, was developed to target T790M, the resistance mutation, to target the drug-sensitive mutations, 19-del and L858R, without targeting wild-type EGFR, the body's EGFR, and therefore causing an effect against the cancer while not inhibiting the body's EGFR, not causing toxicity. And thus, it was intelligently developed to have lower toxicity, less rash, less diarrhea, and still be highly effective against resistance. And so in the first phase 1 trial, the AURA trial of this drug, we saw that the drug had a high response rate against resistance with T790M. The response rate at that time was in the range of 62%, but the activity for other resistance mechanisms, T790M negative, was low, response rate low, PFS low. And so here's a drug now approved only for T790M positive resistance. In fact, the first drug in oncology, to my knowledge, that requires a new biopsy at resistance to figure out if you should use this drug versus a different drug. And so we now can target T790M resistance or can prevent it by using it upfront in the first-line setting. And this model is now being used actually in ALK as well, where there are drugs emerging targeting different types of resistance also. The interesting challenge there is we now need new biopsies to test and target resistance, and getting new biopsies is frustrating for patients. And so that's what's led to the emergence of liquid biopsies. And so when liquid biopsies, in fact, first were FDA approved for EGFR mutation testing, it was really for T790M testing so that you could, instead of getting that biopsy, look for the resistance mutation and treat it. And in patients where their biopsy shows T790M, high response rate, long PFS of 10 months. In patients whose liquid biopsy shows T790M at resistance, similarly, high response rate, 60 or 70%, median PFS 10 months or so. So similar activity if you treat based on the biopsy or the non-invasive liquid biopsy. It's worth noting that there are other targetable resistance mechanisms. And so, for example, MET is perhaps the second most common resistance mechanism, around 10% of patients. And now we have drugs that target MET. There was a recent trial published in JCO combining gefitinib or capmatinib, or the most compelling combination, I think, is osimertinib with a MET inhibitor. That's a trial called the TATAN trial, where osimertinib plus savolitinib has shown preliminary activity overcoming MET resistance. So the idea that osimertinib can be used as a backbone to combine with other drugs to target resistance, I think, is very compelling. What other resistance mechanisms are we looking at? Well, the more we test, the more we find. I've found emerging KRAS mutations, acquired RET rearrangements. There was a case report combining EGFR therapy plus RET inhibitor therapy, acquired ALK fusions, acquired BRAF mutations, all these new acquired mutations in the spectrum of resistance that I think with testing and with the right drugs can be targeted. Currently off-label or in clinical trials, but with time I think our tools for resistance are going to grow and grow.
So you've touched on this briefly, but I'd like to go back to the topic of liquid biopsies because there's a lot of burgeoning interest in this space. Can you please talk about why, how, and when they should or shouldn't be used?
Sure. Liquid biopsies are a way of finding free-floating DNA that's shed from the cancer into the blood circulation. Not all tumors shed DNA. They don't shed DNA when they're responding. all right? They don't shed DNA if they've been cured. They shed DNA generally when they're progressive and when they're more metastatic. And so the time to send a liquid biopsy is when a patient has progressive disease and you're asking a specific question about the character of this cancer. And that can be a patient at initial diagnosis where you don't know their genotype and you want to figure out, are they EGFR mutant or some other mutation, or at resistance where you're trying to find the character of their resistance. There are different types of liquid biopsies, more focused liquid biopsies. The FDA-approved test is the COBAS PCR test. It reliably tests for EGFR, but does not test for other resistance mechanisms. The emerging tools are next-gen sequencing tests. Just like with tumor genotyping, we increasingly use next-gen panels. With liquid biopsies, I'm increasingly using next-gen sequencing panels. There are, I think, a couple tests that now have CMS reimbursement that's been cleared, Guardant and Nevada. These are sort of 30 to 80 gene panels that look for EGFR and ALK and all the various targetable mutations. I think there is no excuse why a patient should go ungenotyped today. Because even if you can't get a biopsy, even if you can't send the biopsy tissue, you can send a liquid biopsy. The challenge with liquid biopsies is that their sensitivity is not perfect. And that's because not all cancers shed DNA into the circulation. When we looked at this in an early validation work, we found, and others have found also, that the sensitivity in advanced lung cancer is in the range of 60, 70, 80%. So you're going to miss 20% of patients at least with liquid biopsies. The more metastatic disease they have, the more likely they shed tumor, and the more likely you're going to find that tumor DNA in your liquid biopsy. So if a patient has liver mets, bone mets, multiple sites of disease, you're more likely to get a productive liquid biopsy. If their disease is limited to the chest, lymph nodes only, you're more likely to have a sort of 50% sensitivity or lower. Still, a liquid biopsy can get you a result non-invasively that you otherwise would need a tumor biopsy for. And the exciting part is that generally, if they're positive, they are trustworthy. They have a high positive predictive value. And so what I do is I send a liquid biopsy first. If it's positive, I can act on it. If it's negative, I say, oh, I might have missed something. I have to fall back on a tumor biopsy as the backup step. And that's really how these have been adopted into guidelines in some of our initial work, for example, with T790M testing. That was clearly our recommendation. Test for T790M in a liquid biopsy first. It can be quick, can take a week. If positive, treat. If negative, fall back on the invasive biopsy, which can take weeks. And that is what's been advocated for in recent guidelines. There was recently a position statement from ASCO CAP describing that as a recommended approach.
So liquid biopsy sounds really promising. Is there still going to be a need for tumor tissue biopsying in the future?
Yeah, that's an important point. I think that a liquid biopsy is a compelling tool. It's one that has limitations, but really is only a shortcut to the biopsy itself, which is still is sort of truth in oncology. I have a case that illustrates this. I saw a patient with EGFR mutant lung cancer, an elderly gentleman. His lung cancer was resected a few years ago. He got standard adjuvant chemotherapy. And then he presents years later, this was now 3 years out, and CAT scan shows a new bone lesion, and he has a bone scan, and that bone scan shows uptake in multiple sites. It looks like he has a new metastatic process. And I think this could have been his lung cancer, it could be a prostate cancer or something else. And what he needs is to know if he now has recurrent disease, stage 4 and curable. And so I send a liquid biopsy, right? And I say, wait, he has an EGFR mutation. Maybe if I find it in the blood, I can sort of replace the need for a biopsy for him. And so I send out the liquid biopsy. It shows an EGFR mutation present, 3% AF. And I actually was like, this is interesting. Does this confirm his cancer is recurrent? And so I asked my colleagues, would you treat this patient just based on a blood test, or does he need a biopsy to prove it? And all of my colleagues in the end say, look, he needs a biopsy. Before you give him the diagnosis of stage 4 incurable illness, that you should have tissue confirmation of that truth before giving them that prognosis and guiding care. And so we did the bone biopsy. It confirmed there was an EGFR mutation in this recurrent adenocarcinoma, and he initiated EGFR targeted therapy, which then proceeded to work for a couple of years. Now, if the patient was sick, if the patient was in the ICU, and I couldn't get a biopsy and I needed something urgent, maybe I would skip the biopsy is the truth, right? And yet there is something very fundamental to biopsies in getting a cancer diagnosis and staging of cancer. We're not going to eliminate the need for lymph node biopsies to determine if a cancer is stage 1 or stage 2 or stage 3. There is a fundamental role in biopsies and how we guide cancer. But for genotyping, and for patients with known progressive stage 4 cancer, this is the single space where the liquid biopsy creates an alternative that efficiently gets patients to an answer that can help guide their care.
So that was really interesting. Thank you. Before we move on to the guidelines and testing nuances, are there any other key takeaways you'd like to convey to the pathology audience?
Sure. I guess I'll summarize that both tumor biopsies and tumor genomics do have a fundamental role in guiding lung cancer care. It needs to be part of the care of any patient with advanced non-small cell lung cancer. The exciting drug that we're developing now for EGFR is osimertinib because of its tolerability, because of its CNS activity, because of the ability to combine this with other drugs, and the data that this now prolongs PFS and may even prolong survival in EGFR mutations reminds us how important it is to get EGFR mutation testing done. And this drug is the first of many others, potent, effective drugs like alectinib for ALK, like emerging drugs for RET, where genotyping guides to improve care and therefore emphasizes the need for genotyping. But then to remember that in those cases where your biopsy specimen is inadequate or where oncologists are worried about getting a biopsy, liquid biopsy is a compelling alternative, but it's a shortcut. And it is very clearly a shortcut that has cut out an important step, the pathologist, in determining the adequacy and tumor content of a blood specimen. And so it's one that we should use in an informed way, but we shouldn't allow it to fully replace biopsies that are so essential in lung cancer care.
Thank you. So let's now focus on the practicalities of molecular testing and the current guideline recommendations. So the molecular testing guidelines were put together by a joint effort from the College of American Pathologists, the International Association for the Study of Lung Cancer, and the Association of Molecular Pathology. And there's two versions of the guidelines. The original guideline was published in 2013, and an update was published in early 2018. The original guidelines emphasized the critical importance of testing two biomarkers, that was EGFR and ALK, for all patients with advanced stage lung adenocarcinoma. And the updates in 2018 reiterated the importance of these particular biomarkers, as well as elevating ROS1 to a must-test biomarker, again, for all patients with advanced stage lung adenocarcinoma. In addition, the American Society for Clinical Oncology has endorsed the molecular testing guidelines with one nuance. In the 2018 guideline, ASCO has actually included BRAF, and that's specifically BRAF V600E mutations, as an additional must-test biomarker for all patients with advanced stage lung adenocarcinoma at the time of diagnosis before they initiate their therapy. So the guidelines from 2018, which we'll focus on from this point forward, reiterated many of the topics from the 2013 document, but there are a couple of really key updates from the 2013 guideline that I'd like to highlight. First of all, in 2013, there was an expert consensus opinion that deemed that any cytology samples are suitable for EGFR and ALK rearrangement testing. However, cell blocks are strongly preferred over smear preparations. That has actually been updated in the 2018 document to include the use of cytology preparations other than cell blocks. And I'll talk a little bit about the rationale for that in a little bit. Next, the 2013 guidelines had a minimum sensitivity of your molecular testing assays for EGFR mutation detection of 50%. That is to say that you had to have an assay that could work in the context of a specimen that had only 50% tumor cells. That usually equates to about a 25% allele fraction of the mutant of interest. That has actually been pushed downward to at least 20% neoplastic cells in a specimen. And that simply reflects the improvements in the sensitivity of the available assays in the clinical testing space today. Finally, there's an elevation of a recommendation to a strong recommendation as it relates to testing for EGFR total protein by immunohistochemistry, and that is you should not do it. That's a strong recommendation not to perform total EGFR IHC for selection of patients for EGFR tyrosine kinase inhibitors. So I'd like to go into some more detail about testing for EGFR mutations. We would advise using molecular diagnostics assays for the hotspot mutations in EGFR exons 18 to 21 at a minimum, and that's those mutations that have at least 1% prevalence in the EGFR adenocarcinoma mutated population. There are some methods that are not recommended for selection of patients with EGFR TKI therapy, and those would include IHC for total protein expression, absolutely not a useful biomarker, but other biomarkers that have been suggested include FISH for EGFR amplification, also not a strong predictor of response to EGFR TKIs. And then finally, EGFR mutant-specific immunohistochemistry is a compelling approach to testing patients for EGFR mutations, but it suffers from a relative lack of sensitivity. So in general, clinicians and pathologists would be advised to perform mutational testing over mutation-specific immunohistochemistry. In terms of other biomarkers, there are strong recommendations for use of routine ROS1 molecular testing. This is for detection of ROS1 rearrangements in particular. This can be performed, or this can be screened initially using immunohistochemistry with confirmation of any positive result with either ROS1 FISH or a molecular technique such as RT-PCR, RNA sequencing, or a next-generation sequencing from DNA to detect a rearrangement. In addition, ALK rearrangements can be detected either by immunohistochemistry or in situ approaches such as FISH, or potentially by sequencing-based approaches. This is somewhat of a change from the original guideline in 2013. This document actually emphasizes that immunohistochemistry can be used as a standalone tool that does not require confirmation for detection of ALK rearrangements. And then finally, if you have access to next-generation sequencing in which you can provide coverage for a broader panel of oncogenic targets, the guidelines would recommend including ERBB2, MET, BRAF, which of course we've discussed as being now a critical biomarker according to ASCO, as well as KRAS and RET. And we can anticipate that that panel will continue to grow in time. Indeed, things like NTRK will be biomarkers that no doubt we will want to be able to detect more routinely because of availability of drugs that are effective in patients who have TRK rearrangements as well.
Can I ask what the testing method at your institution is? What's your standard approach today?
Sure. So at our institution, we have really a hybrid approach to testing our patients. We have screening assays that we utilize, immunohistochemistry principally for ALK and ROS1, which enables us to get a result back in usually less than 24 hours for those particular biomarkers. We have what we call a rapid EGFR test, which gives us information about the most common hotspot mutations. That's the exon 19 deletion and the L858R mutation. We use something called droplet digital PCR, which is a highly sensitive assay, which is very useful if you have a very small specimen, a specimen that's highly contaminated by benign stromal tissue, or if you need a result very quickly and you don't want to wait for a larger, more comprehensive test to know the EGFR status. Finally, if we have a little bit more time, and we want to get a broader mutational panel, we have a large hybrid capture next-generation sequencing assay, which covers several hundred genes and provides information about rearrangement as well as copy number status, and can be used either in the diagnostic or at the relapse setting.
So which patients do you offer this approach for with non-small cell lung cancer?
Right. So I think it's important to keep in mind that not every patient with a targetable biomarker necessarily has an adenocarcinoma morphology in their tissue sample. And we focused on adenocarcinoma patients in particular, but the reality is on very small samples, sometimes you can't perceive a morphology. Sometimes a specimen will be very poorly differentiated and simply doesn't read the book about what it should look like. And there are other scenarios where a tumor can actually appear, for instance, to have squamous morphology, but it can still have an underlying targetable biomarker that we often associate with adenocarcinoma biology. So as a result, the guidelines have emphasized that if you have a patient with non-adenocarcinoma histology, but they have clinical characteristics that you often associate with a targetable biomarker, and those would include younger age, young being defined typically as less than 50, or if they have never smoking or light smoking history, these are patients you should consider strongly for getting clinical biomarker testing. Finally, in terms of approaching your testing from a methodologic standpoint, in general, we recognize that across the world there's quite varied resources in terms of types of platforms you might have available for testing. We would generally recommend that if you do have access to panel testing, tests that can provide an approach to multiplexing, that would be preferred over performing single gene assays. The reason being that sequential single gene tests may lead to exhaustion of the tumor tissue before you can actually deliver a fully comprehensive genetic profile. In the resistance setting, the patients who have progressed on a EGFR TKI, the guidelines will recommend testing specifically for EGFR T7-IDM because, as you earlier pointed out, 50 to 60% of patients on drugs like erlotinib or gefitinib or afatinib will evolve a T790M mutation. And I think what's quite distinct from the recommendation for first-line testing of activating EGFR mutations, for resistance mutations, assays should be validated to a sensitivity of 5% tumor cells. And that's in recognition of the fact that T790M can occur as a subclonal alteration. So you can see quite a bit of heterogeneity in your patient samples, and you need to be able to detect these types of mutations at a much lower level than the EGFR activating mutation. Finally, getting to the role of cell-free plasma DNA testing. This is recommended in cases for patients who have limited tissue. It is not recommended in the context of a primary diagnosis. And I think importantly, getting to the point that you made earlier, it is not suggested to be used in lieu of obtaining a proper tissue biopsy to make a diagnosis of cancer before proceeding with definitive therapy. It's also potentially highly valuable, again, as you pointed out, for use of identification of EGFR T790M mutations. Ultimately, if your T790M test is negative on the plasma, the guidelines would recommend moving forward with testing for tissue before making a decision about next line of care. So just to summarize the who, what, and when of molecular testing, the guidelines emphasize advanced stage lung adenocarcinoma patients should be getting tested. Of course, again, the caveat being that if their clinical history suggests that they may have a targetable biomarker despite not having a lung adenocarcinoma diagnosis, they should still be considered for testing. What should we be testing? From the standpoint of EGFR, we should be performing molecular testing for EGFR mutations, not IHC and not FISH. An assay should be sensitive to at least 20% tumor. If you're looking for a resistance mutation, T790M in particular, you should be working with an assay that is sensitive down to 5%. These mutations tend to be consistent regardless of the site that you biopsy. And then finally, the options to test in terms of sample types may include a biopsy specimen or a cell block or cytology preparation, such as a smear preparation. So when should we be testing? Either at the time of initial diagnosis of advanced disease, at the time of progression following a prior diagnosis with an earlier stage disease, or at the time of resistance. And then finally, there's the concept of potential reflex testing. And this is really, I think, very much an institutional decision. So should every patient who has a lung cancer or lung adenocarcinoma diagnosis undergo reflexive testing within your institution? There's many issues related to that. If that's something that an institution wants to support, that may be feasible in some instances. It's often hard to get reimbursement for testing earlier stage patients, but it's certainly something that individual institutions may consider in their own practice.
So how should a pathologist handle path specimens to maximize the chance of successful molecular testing, given all these various targets that need testing achieved?
Yeah, so I think that's a really important point, and I'd like to start by just setting the stage in terms of the type of materials that we're typically dealing with in our practice. So to begin with, about 70% of patients present with lung cancer at an advanced stage with unresectable tumors, which of course means that we're going to be getting small biopsies, not large resection specimens to work with. Secondly, 70% of lung cancers are diagnosed either on a small biopsy, such as an endobronchial biopsy or a transthoracic biopsy or some other needle biopsy, or on a cytology specimen. And then finally, in about 70% of patients, that small sample may represent the only specimen we will have for an individual patient. So in many cases, you have one shot at getting this right. And there's several challenges that we face in routine clinical practice, and I would categorize those as quantitative challenges and qualitative challenges. And this is really partly about the type of biopsies we get, as well as the pre-analytics surrounding specimen handling. So a couple of important points to make about the quantitative challenges. Number one, we have to get enough DNA out of specimens to actually run our molecular tests. And every assay has its minimum requirement. And I would point out that as time goes on, we get increasingly better at reducing what those minimum requirements are for DNA input. That's going to be, of course, driven by the size of the sample that we get, the overall size of the sample. But then, of course, the other variable is how much tumor is in that specimen. What is the relative content of tumor to benign stroma? And that is ultimately what drives the sensitivity challenges. If you have a very large biopsy, but only 1% of it is tumor, that's going to present a challenge. Whereas you could have a very small biopsy, but 100% of that is tumor. As long as you can get enough DNA out of that sample, it may be a very good sample to proceed with for molecular testing. From the qualitative standpoint, there's a couple of really critical adverse factors to keep in mind. Number one is poor fixation, and that could be defined as a long period of time before the specimen actually lands in a fixative, like formalin. 10% buffered formalin is the recommended fixative. It could be a function of overfixation, and this can be an issue for, say, small biopsies that sit in formalin for, say, 72, 96 hours or beyond before they actually go into routine processing. Inadequate fixation can sometimes be an issue for large resection specimens where the formalin doesn't have an opportunity to actually penetrate to the center of a large tumor, and potentially the center of that tumor would not perform well for molecular testing or potentially for immunohistochemistry. And then finally, another major challenge that we face, in particular for our patients with bone biopsies, is that of decalcification. We have to perform decalcification in order to create the histologic cut sections that we need to do our analyses, and we require a removal of the calcium from the biopsies, historically using relatively strong acids which lead to degradation of the DNA. Fortunately, we've seen some improvements in decalcifications that have enabled us to use those biopsies more readily. I wanted to talk a little bit about ways that laboratories can address some of the challenges around small size of biopsies, and that has to do with partly thoughtful communication with your ordering team so that you can anticipate a need for genomic testing on a small biopsy, and then developing protocols within the laboratory that you can use routinely when you have a specimen that you know is going to require a lot of downstream analysis. So in one example, you may choose to cut your H&E slide to evaluate diagnosis, to assess the tumor content, cut a large number, anywhere between, say, 10 to 15 to 18 unstained slides, and then sandwich that with another H&E to confirm that you still have tumor on the back end of those 18 or 15 unstained slides. And then you can make use of those slides by triaging some for, say, diagnostic immunohistochemistry, particularly in the initial diagnostic workup, some for screening testing, such as immunohistochemistry for ALK and ROS and PD-L1, setting some aside for direct delivery to the molecular diagnostics lab, and then maybe having a few for backup for FISH, et cetera.
What's the downside to cutting all these extra slides up front? Is there an extra cost, or is there some reason why pathologists wouldn't want to do this?
Sure. I think you have to be thoughtful about this type of approach because this is additional work, obviously, for your histology laboratories. It is additional storage space. Somebody has to sort of manage these slides and where they live. It does present some incremental costs, both in terms of labor as well as financial to a histology laboratory, which I think it's important to be thoughtful about when you do this type of upfront processing, which is why I would emphasize the role for communication with the oncologists. Another important point to make is that typically you want to be using these types of slides within 3 months or so of being cut, because you can see things like antigenicity declining over time, particularly for sensitive immunohistochemistry assays. So it's important to actually make sure you're able to use these for that type of testing within a few months of cutting the slides. If you anticipate that you're not going to use the material in, say, several years, then obviously there's less of a role for this type of upfront triaging.
But for a patient who needs molecular testing, it increases the chance that the slides are available when that ordering is done and they aren't exhausted when you're rehandling the specimen.
Exactly. Mm-hmm. So just to get to some of the other qualitative issues in terms of sample selection, a couple of recommendations in terms of how you handle the fixation. Biopsy specimens should really get into formalin immediately because the longer they sit out at room temperature, not in fixation, the longer they have time to degrade. And this has adverse effects on both the way it looks under the microscope from a morphologic standpoint and the quality of the DNA and the protein antigens. Larger resection specimens, it's really not realistic to dunk them in formalin immediately, but ideally if you can get them into formalin within about 30 minutes, that would certainly enable optimal fixation for molecular testing. And it's important to use 10% buffered formalin, and total fixation time, typically what is suitable is between 6 and 48 hours, shorter periods of time for small biopsies, longer periods of time for larger resection specimens. Again, it's important to avoid decalcification, emphasizing that it's these acid-based decals. The standard traditional decalcification solutions have used hydrochloric acid, and that's very destructive to nucleic acids, also to protein epitopes. EDTA-based solutions are actually much gentler, and they can remove those calcium ions without causing as much of a degradation for molecular results. And then finally, cytology specimens, as we mentioned before, now more broadly as a class are being considered as acceptable for molecular testing. This is assuming that an individual laboratory has actually validated their tests for the different type of pre-analytics you can see with various cytology specimens. And in particular, smear preps often undergo an alcohol fixation step, which actually is less harmful to the DNA than formalin fixation. So if you actually look at sequencing quality metrics, so what is the quality of the molecular data you get from these specimens, it's actually as good as, if not better than FFPE tissues, looking at them head to head. One of the, I think, perennial questions for both clinical providers as well as pathologists is, what is the best approach for actually obtaining a specimen? If you have a choice of a core biopsy or a fine needle aspirate, what should you do? The jury's still, I think, out on this. There's really no consistent consensus on the best modality. It's really going to be heavily influenced by the practice at your local institution. What is the preference of your interventional radiologist or other operator for obtaining a specimen? Are they more comfortable with core biopsy versus fine needle aspiration? What is the available of services from your cytopathology division, such as rapid on-site evaluation? Having access to that type of resource may help for triaging of specimens more directly, say, for molecular testing, if you can identify a cellular smear, for instance, directly from the rapid on-site scope, it may be able to facilitate more rapid turnaround of specimens into the molecular laboratory. Of course, there's considerations relating to the patient in terms of risk for a larger biopsy versus a fine needle aspiration. And of course, this type of choice may be driven by just the location of the lesion in the patient's body as well. So to summarize, the emphasis for the guidelines has largely been on advanced stage lung adenocarcinoma, but as we discussed, it's also applicable to other forms of lung cancer in the appropriate clinical context. The types of testing we can do can be off histologic specimens or cytology specimens, including the cell block or other preparations. The EGFR guidelines in particular focus on the 20% cut point in terms of a sensitivity for your assay, and that's the percentage of tumor cells that you should be able to see in your specimen to permit for molecular testing. For the resistance space, T790M mutations should be detectable down to 5% tumor content in your specimen. And then finally, in terms of circulating cell-free testing, again, not recommended for primary diagnosis, can be useful both for detection of activating EGFR mutations as well as for a resistance mutation with a T790M. If those are negative, tissue testing should be reflexed.
All right, that was a spectacular review of the new guidelines, which have just been updated this past year. So given those practicalities, let's talk about some scenarios and how we apply those to a couple cases, okay?
So the first case is a 55-year-old. She's a never smoker, has an incidentally found PET positive right upper lobe lung mass and supraclavicular lymphadenopathy as well as a suspicious liver metastasis. She actually undergoes a CT-guided core biopsy of the lung mass, and pathology shows a combination of P40 positive nests as well as P40 negative areas of tumor that show frequent mucicarmin positivity in the tumor cells. So this pathology is a little bit unusual. Our evaluation of this would suggest that it's an adenosquamous carcinoma. On a small biopsy, we may not be so definitive. We may suggest a diagnosis of adenosquamous carcinoma. What would you recommend as a next step for this patient in terms of molecular testing?
For my mind, I see a never smoker or even a light smoker, and I want to get that genotype, no matter what your pathology reads out. And you can get all sorts of confusing pathology reads. They sometimes say, you know, even a neuroendocrine. I've seen small cell and never smokers. They'll throw in there like, you know, positive for some random IHC, could be kidney cancer, you know, and it's like the wild card throws you off, and you have to be laser focused that in that never smoker with what looks like lung cancer, or even a light smoker, you need to get to genotype. And so adenosquamous does not faze me and does not slow me down. I do think that molecular studies of adenosquamous have suggested it's pretty much a flavor of adenocarcinoma. It's not some mixed flavor of adeno and squamous, it's just another variety of adenocarcinoma. And so I would get that patient at genotyping as quickly as possible, just as I would with a poorly differentiated carcinoma, a poorly differentiated carcinoma with neuroendocrine features, a poorly differentiated carcinoma with sarcomatoid features. In that patient, certainly with a never, or even a smoker with a confusing non-small cell lung cancer, genotyping is essential. The only case where I pause is in really a pure squamous carcinoma in a good solid biopsy. So a smoker with a resected squamous cell carcinoma, that's the kind of non-small cell lung cancer where molecular genotyping really is just slowing you down. What you want is PD-L1 and you have other decisions on your mind. Otherwise, getting EGFR testing and waiting for molecular testing in a patient like this is really, really important. Okay. Would you agree?
Yeah, I agree. I think adenosquamous carcinoma is relatively unusual. It's probably between 1% and 4% of the non-small cell carcinoma diagnoses that we make. And I think to your point about its similarity to adenocarcinoma, the molecular profile is actually very similar to what we see in adenocarcinomas, and the rates of EGFR mutation in particular are probably fairly comparable. So it seems very reasonable that we would proceed with molecular testing in this patient. Mm-hmm. So the next case I'll pass over to you to lead through.
Sure. This is a never smoker who presents EGFR mutant lung cancer, 60-year-old, had started on an EGFR targeted therapy a year ago, and now after 12 months of therapy with a nice response has developed resistance. We're seeing these patients more and more. The patient has a PET scan. It shows a positive lesion in the rib and in the spine, and ends up going a bone biopsy, which is something we need to do for resistance genotyping, but it's a little more complicated. The IR-guided biopsy is ordered. The patient has an FNA done of a soft tissue area and a core biopsy of the bone, and these results come to you, the pathologist, both showing non-small cell lung cancer. How do you triage these specimens to get us the molecular testing that we need?
I wonder if we could back up and just ask about the decision to have the operator get both the soft tissue biopsy as well as the bone biopsy. Is this a conversation that you sort of have with the folks getting the material, or how does that proceed?
From an oncologist standpoint, I will say I often will initiate the conversation. How well it follows through, I don't always have control over. I would love it if every procedure included an FNA to localize and then a couple of cores to follow through, and that gets the most tissue with the most accuracy. But there isn't always a cytologist available for on-site evaluation. Sometimes it's too high risk and they don't want to get the core, so they just do the FNA. In this instance, specifically with a bone biopsy, I'm a little more proactive, encouraging the radiologist to get multiple specimens to cover my bases.
Right.
I will say I would generally avoid a bone biopsy, but if it's a small lesion that's inaccessible in the lung and all that's available is in the bone, I need to go with the bone. And so in the end, you need to put a needle into what's available and then hope you get back the tissue that let you get the results you need.
Right, and I think from the pathology standpoint, obviously we're evaluating the adequacy of both the bone biopsy as well as the FNA, and then as we discussed, the pre-analytics are critical. So if you have an opportunity to decalcify a bone biopsy in an EDTA or another gentle decalcification agent, you can potentially utilize that successfully for molecular testing. Alternatively, you may want to be falling back on the FNA specimen to carry out the molecular testing. So we'll assume in this case that the sample is say, insufficient for molecular testing. What would you do at this point?
Yeah, honestly, if it's insufficient or even if it was tested and was negative, I would still have suspicion about whether it was a high-quality specimen, let's say given it was a bone biopsy and decalcified. And so there's where we use that liquid biopsy as a backup. I actually just had a case in clinic where EGFR genotyping of a bone biopsy was negative, and so a liquid biopsy which found high levels of an EGFR mutation. And so we assume there that that's not a false positive, that the blood test actually trumps the tumor specimen because the tumor testing was maybe testing of a poor quality specimen. And so that liquid biopsy is this fallback plan when our tissue is insufficient, or maybe I, as the oncologist, ask my pathologist, please test it, just let's try. And it's sent out and it's negative, but it's negative with an asterisk saying, it's negative, but it wasn't a very good specimen. And so in that instance, I use that liquid biopsy sometimes as a backup plan when the biopsy didn't work out. I will say that a liquid biopsy also has its limitations. In a patient with bone metastases, there's more likely to be DNA shed, and a liquid biopsy is an opportunity to find something that might have been missed. And so I will often use a liquid biopsy as an alternative to a biopsy, especially in bone mets, where biopsies are less reliable.
Okay, that's really interesting. Okay, so let's go on to one more case. Marries a couple of these concepts together. And this is a patient who's 75, She's a light smoker. She has a history of a cough, which prompts a CT scan showing a large, again, lung mass and also a pleural effusion. So in this particular scenario, the decision was made to proceed with the pleural fluid drainage and evaluation of that by cytology, and that showed a TTF1 positive non-small cell lung cancer. I would ask you at this point, what would you suggest for this patient at this point in time?
That's something we commonly will do. We will tap a pleural effusion. It's an easy way to get tissue, easy way to get a diagnosis. The quality of that tissue is a separate question, I think, and that's where we need our pathologist to pull through for us. So in a older, light smoker, especially, I would love to find a genotype. A current standard of care for a newly diagnosed non-small cell like that is going to be 3-drug chemotherapy with immunotherapy, perhaps, a fairly toxic regimen for an elderly patient, though certainly an effective regimen when it works. And so I'm looking for a molecular test to give me a targeted therapy option. So I would send the pleural fluid block, the cell block, for molecular testing and hope I find something.
Okay, so I'm going to push you further on that, and I'm going to tell you we got PD-L1 testing, and it was 80% positive, so a tumor proportion score of 80%, which we would consider positive and potentially make them eligible for pembrolizumab monotherapy in the frontline setting. We also discovered that we've sent the specimen off, to your point about pleural fluids not always being optimal, maybe because of cellularity challenges. We send it off for molecular testing, and it's insufficient for testing. So what do you do now for this patient?
Right. First-line immunotherapy is a compelling option, and it can be very effective when given to the right patients, and can be entirely ineffective when given to the wrong patients. And so PD-L1 is this biomarker that helps guide us, but not very reliably. And I think of PD-L1 positive as coming with an asterisk sometimes, right? PD-L1 of 90% in the right patient who's a former smoker with the right genomic makeup can be associated with a fantastic response and durable response to immunotherapy. But PD-L1 positive in a patient with an EGFR ALK arrangement, that it's not appropriate to give first-line immunotherapy, and the response rate is in fact very low. And so I think a patient like this today would be pushed towards immunotherapy, or if you're not sure about it, chemoimmunotherapy, 3-drug therapy. And I'm a little bit dissatisfied with that. What I really want is the molecular testing to clarify if this is a PD-L1 positive that I can trust and is going to be associated with great single-agent outcomes, or a PD-L1 positive that comes with an asterisk and isn't as reliable if it's present in an EGFR and ALK. And so in this patient, light smoker, I would have a conversation about it. One could try just giving the immunotherapy and see how it goes, but you really want to get that molecular testing as a backup plan, because if it doesn't work out, you're back to the position of saying, wait, I'm stuck with an ungenotyped non-small cell lung cancer patient where I don't know about available oral therapies. And so if the patient's up for it, I would push for more tissue to get to the answer of that.
And what about a liquid biopsy in this patient?
Yeah, it's a good question. Liquid biopsies can be tried, not as reliable in a sort of 4A like this with lung disease, pleural effusion. I mean, we could try liquid biopsy and a biopsy. How much time do we have to spend here? We could send a liquid biopsy while we start immunotherapy, while we order the biopsy. There's a way to piece it all together, but in the end, I want to chase a genotype. And if it's easy enough to get a core biopsy, I think that's probably more reliable in this kind of patient, though many of these patients would get liquid biopsy first as a shot to see if it's going to work out.
So let me give you some follow-up on this patient. A liquid biopsy was ordered but returned as uninformative, presumably not enough shed in this context. And so a lung core needle biopsy was obtained of the primary lung mass, and that confirmed, of course, the diagnosis of adenocarcinoma and showed an EGFR exon 19 deletion mutation. So I'd ask at this point in time, what would be your suggestion for therapy for this patient in this context?
So here's a case where testing, follow through, the patience of getting to the right answer helps us get to the right treatment. This patient would benefit from first-line EGFR therapy. Our standard of care today is osimertinib, and that can lead to a dramatic and durable response lasting years. But such a patient has little, if any, benefit from immunotherapy, might have benefited from chemotherapy, but it's not as good as EGFR therapy, and chemoimmunotherapy would have been off-label and not clearly more effective in an EGFR-mutated lung cancer. And so here, by following through, getting the molecular testing, we get them on to the most effective and reliable therapy, which gives them, treatment options down the line, chemo, immunotherapy, but the best chance of having a response today.
Okay, and indeed she received osimertinib. She had a dramatic response. Her pleural effusion resolved. She had significant shrinkage of the lung mass within about 2 months from initiating therapy. And of course, unfortunately, as things go with patients who receive TKIs, she ultimately does go on to progress. It took about 16 months before she started having symptoms again. She had a repeat CT scan at that point. She actually had bilateral lung disease, and she underwent an FNA of the lung mass, obviously to confirm the relapse diagnosis and to get some additional material for relapse resistance testing. And so an FNA was actually performed. Both a cell block and a cytology preparation were made. The cell block was actually very paucicellular, and although we could do some immunostains just to confirm an adenocarcinoma diagnosis, there was not enough material to do any other additional molecular testing. So we are left with a cytology smear preparation only in this particular case. So potentially this is something, of course, we could use for molecular testing based on the current guidelines. This type of preparation is acceptable, again, assuming that a laboratory has validated this type of specimen for testing. So this can get complicated because not every, for instance, commercial laboratory is accepting cytologic smear preparations for testing. So I think maybe we need to give some thought into whether there's a utility to doing additional molecular testing in this setting.
I mean, after osimertinib, the standard of care has now become chemotherapy, right? We took our best EGFR inhibitor, we moved it up front, and now we're left in a space where resistance testing is a little more investigational, but has an opportunity to find mutations like C797S that could be targeted with the older EGFR inhibitors, erlotinib, gefitinib, afatinib, and still MET amplification seen in maybe 20% of patients in this kind of setting, and other resistance mechanisms, including small cell transformation, which can be seen 5 or 10% of the time and can lead to a dramatic phenotype and needs aggressive chemotherapy.
I can actually ask about that. Can you anticipate clinically that a patient has small cell transformation when they present to you at relapse?
No, I'm always thrown off when it happens. The more biopsies you do, the more you see it, but I'm never, it doesn't really look like small cell in advance. It's only when you get the biopsy back that you realize, and maybe it's a spectrum of other cancers that have aggressive resistance, and that's just one of the phenotypes of aggressive resistance. I still think that the role of biopsies for resistance is fundamental, and the opportunity for molecular testing here is to find a number of variants that can be targeted with combination therapy, MET, EGFR, ALK, RET, all of these have been described for acquired resistance. So I would push for molecular testing of this patient. If the smear is adequate, I would try to get NGS, look for options, because otherwise we're stuck back where we were before, where the patient needs chemotherapy as the only tool we have.
Okay. So in this particular case, the smear, indeed, it was adequate. It was sent for testing, and no mutations were identified other than the original EGFR activating mutation. So what do you do at this point?
So this patient has had a good run with targeted therapy, now needs standard of care chemotherapy, and so I would use platinum pemetrexed, assuming the patient's in adequate performance status. And I still, in such a patient, rotate back to immunotherapy, to targeted therapy later, and clinical trials, et cetera. But here's a patient who, where genotyping at resistance hasn't really panned out for them. I still think that we can do more and more, and we are working on clinical trials for this space to find a role for osimertinib resistance testing in cancer care today.
Okay. And I wanted to just wrap up with one final question, and that is, let's talk a little bit about coordinating specimen handling and the type of communications that you think are really optimal to go on kind of across disciplines within an academic center, within a hospital, any setting really that's going to best facilitate optimal molecular testing for lung cancer patients.
Right, and what it needs is brisk communication between the oncology team and the pathology team, and that can be email, that can be, I text my favorite pathologist, that can be paging, and whatever you need to do, you need to have that back and forth to make sure that specimens are tested appropriately. And every time I don't reach out to my pathologist about a case, I end up regretting a little bit, right? Because it's not handled the way I was thinking. And so clarifying on your requisitions, on your orders, exactly what you're looking for, clarifying the case and making it clear, resistance testing is what we need, reaching out to your interventional radiologist to be clear about your needs will give you the best chance of having a result that you're looking for and help your patient. But and even if the first specimen doesn't work out, it's worth trying again. It's worth persistence, because testing leads to results that help our patients, and testing is a priority.
Terrific. I think this has been a great discussion, bringing together perspectives from both oncology and pathology sides of molecular testing, and show how these can guide the current management of patients with EGFR positive lung cancer. Jeff, do you have any concluding thoughts you'd like to share?
We should acknowledge the tension in oncology now, certainly in lung cancer care, where there is a compelling empiric option, chemotherapy plus immunotherapy, which is available for really any patient's first line with non-small cell lung cancer, even small cell lung cancer. And yet that 3-drug regimen that has shown improved outcomes in a number of trials is not appropriate for EGFR mutant lung cancer, is not appropriate for ALK positive lung cancer. And falling back on that empiric approach loses out on precision approaches that are extremely compelling as well. Single agent immunotherapy needs testing. EGFR targeted therapy, ALK therapy, BRAF, ROS, RET, HER2, MET needs testing. And so we shouldn't allow ourselves to fall back onto the empiric therapies that really we developed 10 years ago, sort of historic approaches. Precision therapy is the best way to give our patients the best outcomes, and we need to push forward and make sure all patients get tested.
Well, thank you very much for joining me today, and I hope that all of you listening have found this discussion informative and useful to your practice. Thank you.
Thanks.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/DZD. This activity is supported by an independent educational grant from AstraZeneca. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.